tūtaua mai I runga, tūtaua mai I raro, tūtaua mai I waho, tūtaua mai I roto, kia tau ai te Māori tū, te Māori ora ki te katoa, haumi e, hui e, tai ki e. Kia ora koutou, welcome to our webinar tonight on ED outcomes, proven how Healthline is changing ED care, which is pretty exciting and something that we're really passionate about at Collaborative Aotearoa is around how do we best serve the people that we are wanting to serve within our community. So it's an absolute privilege to be bringing you, our members, our stakeholders, our industry, our sector, this really interesting corridor, which has had a bit of build up in the media this week, which is going to be really exciting. So a little bit of housekeeping. We've got the Q&A function up on the top kind of banner ribbon. You can click there, ask questions. I'm really good at reading your questions instead of the ones that I've got on the screen. It just makes our kind of panelists have to work a bit harder, and I'm all about that at 7 o'clock on a Wednesday night. So use the Q&A function and we'll get you nice and interactive within the session. And also, we love a little bit of emoji. So if you're going to react, a bit of a thumbs up, a little bit of a laughing face, always makes for a fun webinar. So do feel free to interact with us as we go. I'm going to introduce our panelists for you this evening, and then we'll get hot and heavy into our really interesting panel discussion tonight. So I'm going to introduce to you in order 4 really pivotal people to this piece of work. Firstly, I'm going to bring it to you Associate Professor Michael O'Sullivan from University of Auckland. Key to this piece of work. We were a little bit stressing prior to coming on when he wasn't online, and we were all like, it's a little bit awkward when the researcher doesn't show up and we've all got to kind of figure out what to say. So really grateful that you've joined us tonight, Michael. So from University of Auckland and from Te Punaha Matatini. If you don't know what that is, most of us didn't know what that was either, but it's a really cool collaboration of researchers from across Aotearoa who are hosted by Auckland University, doing some really cool stuff for our sector. So if not anything, you've learned that tonight, that really cool group of people exists. We've got Dr. Ruth Large, who's our Chief Clinical Officer at Whakarongorau, telehealth and emergency medicine expert. We've got Dr. Matt Wright, our urgent care physician at Whakarongorau, and we've got Melody Mitchell, Operations Director, Medicine and Older Persons Rehabilitation at Te Whatu Waikato. So brilliant to have you all join us this evening to get in and talk about ED and really around the model of care and how we can disrupt that a little bit by introducing some telehealth services. So Ruth, I'm going to kick off with you and ask you to paint us a little bit of a picture about life as an ED physician. What does that look like for you? The current ED pressures that you're experiencing and your colleagues are experiencing across Aotearoa, and why this research really matters.
Yeah, thanks, Jess. And, to be fair, I actually don't do that much clinical work anymore. So, Matt may be better to give you a little bit more perspective on what it feels like, to be on the floor. But, from my perspective, I've been working in emergency departments now for, 20 years or more, and more than half of that as a rural hospitalist. And there is no doubt that emergency departments are getting busier. Our focus really has been on the waiting room, and that's been an area of interest for me, particularly in access to healthcare. So there's also no doubt that waiting rooms are dangerous places, and they're becoming more so. We see that in the literature, and we also see that reflected in some patient outcomes, as well as privacy concerns, right? When you've got a queue, sometimes Matt and I will come on to queue out the door, on a shift. And from my perspective, I've either worked, credentialed, or visited every rural emergency department in the country, and it's even more so in rural. We see that really, really big impact in waiting rooms in emergency departments. So I guess when I looked at this from, why is the research important? For me, I've had a long interest in telehealth. the Healthline has been of interest to me, but actually there is no really robust evidence looking at the impact of telehealth on emergency departments. That which is coming out is very doctor-centric, and we've got this unique, beautiful thing in New Zealand of nurses and working to top of scope and paramedics to working to top of scope. So we've done a bit of research over the last few years since I've been Chief Clinical Officer and a bit before that. But this piece to me is really, really important because you want to know that your taxpayer dollar is going where it needs to go. So that, to me, that's key.
Beautiful. Matt, do you have anything to add from your perspective as a physician and as someone who's been, I guess, overseeing this kaupapa?
Yeah, thanks, Jess. So I've been working in the ED at Middlemore for 15 years and I've done around about that same time in the community and urgent care clinics as well. So I have a view, I guess, on how things work within urgent care, within community care, but also within the ED. And like Ruth, I spent a lot of time in the waiting room in that lower acuity zone. And so what I've noticed and what the data would support that over time, or at least in Auckland, is that that slow increase in volume has happened kind of 2018 to 2022, but in the last 1 or 2 years, that volume has ramped up more so to the highest it's been, at least in Metro Auckland. But what has happened is that the acuity is going up in the EDs, throughput is impacted by bed block, but there's still about 40% of people, which are triage 4 and triage 5, attending emergency departments throughout New Zealand. Now, T45 is quite a blunt way of saying, who might not need emergency department, who might need other care. But even if that 40's 30 or that 30's 25, that's still quite a significant proportion of people that at triage, which we know is usually relatively accurate, is actually is a group that what more could we do them? Can we do something different? Can we do something better? Instead of sitting there, sometimes Ruth and I have to move and push past all the people in the waiting room to get to the people we're trying to find. And when we say a name, we sometimes get 3 people get up because they hope it's their turn, which could be a 3, 4, 5, 6, or even longer hour wait. And probably just to say that sort of acuity, but also having those 4s and 5s is actually happening at the urgent care clinics as well, where the triage 1 to 3 proportion has doubled in the last 2 years, and the triage 4 proportion has actually doubled as well. So urgent care clinics and EDs are both getting more acute, but there's still a lot of that lower acuity stuff which can be done by other mechanisms, including telehealth.
Yeah, beautiful. It's painting a pretty grim picture and not painting one of any of us wanting to go and probably line up at an ED to seek out care. So having alternative options for whānau that don't need to be there is a really awesome option and something that we are really interested in. I think it's something that, we're all passionate about. And it was interesting when we were planning for the webinar, and I was a little bit resistant at the start because I was like, we don't want people just all being deferred back to the GP when we've got such a big pressure point in the GP space. And I think one thing that I learned this week, and I'm sure a whole lot of other people on this call probably didn't know this, and Matt and Ruth are going to give me the correct number, but there is a large amount of people who are having their results or are being triaged or are having problems solved by Whakarongorau, by Healthline, which is not resulting in a GP appointment and is not resulting in other kind of hospital level care. So is being fully resolved within that phone call. And I think that that's just a really timely place to kind of, I guess, have that little bit of a corridor that we are here to make sure that people don't just get reverted back to the GP, because I'm sure a lot of our whānau on the call are from primary care and are feeling the pressures themselves in that space. So just wanting to kind of put a bit of a recognition out to all of the work that we're all doing in the sector. And it's not just about solving for the hospital problems, but actually solving for whānau's problems when they are needing to be seeking care or they need to have care given to them. So just wrapping that in there. Now we're going to go to the researcher that did join us this evening. So Michael, we might flick over to you. This research gives us some pretty fascinating findings, and I know you're just giving us the interim kind of high-level findings tonight, but can you tell us what it did show you and what you learnt through the process?
Yeah, kia ora. Thanks, Jess. Lee, if you could pop the slides on, I'm going to talk first through the methodology we used in the research, and then I'll go through a bit of a summary of the numbers, and then pass over to Melody to tell us what that all means. So as you see on the slides there was two things that we were wanting to measure. One was how many people were coming to ED that we thought would have been able to avoid ED, and in fact avoid any GP care, A&E care altogether by going through Healthline, so they were appropriate to go through Healthline, and from Healthline take care of themselves or their loved one. We also wanted to see how many ED visits have been avoided by Healthline, so how many people go to Healthline that otherwise possibly would have turned up with ED. So I'll just talk to you those two methodologies first. So for the avoidable ED visits, we start off with ED records throughout Te Manautaki, and we classified a patient as appropriate for self-care, i.e. if they rang Healthline, they'll be able to take care of themselves at home. If they arrive by car, if the outcome of the ED visit was self-discharge or routine discharge, and if their condition was considered a triage code 4 or 5. We're looking now in the next phase of looking into refining that with diagnoses, but the numbers I'm doing today, that's the classification. So we applied that to each of the different locations, Waikato, Taranaki, Bay of Plenty, lakes, and then for each of those areas, we found the number of avoidable ED visits in each area. In order to determine how many ED visits Healthline managed to take care of themselves, we looked at all the Healthline calls. Matt very kindly provided us with clinical risk categories. So for each of those Healthline calls, we could categorise it as being low, medium or high in terms of its clinical risk. And then for each of those categories, we had a probability of if that person would have likely gone to ED if Healthline was not available to help them do self-care. And this was for over each of the risk categories, and for both an in-hours event or an after-hours event. And that means we would get an expected number of extra ED presentations that would have occurred, or the estimate would have occurred if Healthline had not been available to care for those patients. And so the key findings for that is, in terms of the presentations avoided because Healthline was there, about 40% of ED visits were avoided by Healthline being active, and that was around about 80 people per day across the Te Manautaki region. And the time period we looked at was from July 2019 to June 2024, and that was across, again, all of the different regions, all of the different areas within Te Manautaki region. And in terms of the ED presentations that still could be avoided if they had gone to Healthline instead of showing up to the ED, it was about 6% across the Te Manautaki region, and that's about 35 people per day. And again, this is a potential self-care group that came to ED, and actually if they rang Healthline, they probably would have had to make that visit and have that wait. So we had a little bit of a look at the demographics of the people who came to ED that probably would have actually been more appropriate to ring Healthline and go through self-care. And in that we had a high proportion of younger and older people than people in the sort of mid-age range of 30 to 69. So less than 29 or younger and 70 or older. We had a high proportion of male than female in that group coming to ED. We had a high proportion of both Pākehā and Māori, and a lower proportion of Pacific and other ethnicities. And we had a higher proportion of people with high deprivations that coming from deciles 7 to 10 than people who are living in areas with deciles 1 to 6. And again, this is really initial analysis of what that group looks like. And in our next phase of work, we're going to look at both some of the clinical or the diagnostic meanings of those groups, and also look more clearly into the demographics. Melody, sorry.
Kia ora. And good evening to everyone online. Great to see you there. Firstly, I'd like to acknowledge actually the work that has been done so far, and the collaborative approach with the University of Auckland team and Whakarongorau. As Ruth mentioned earlier, actually that we haven't been able to do this kind of approach until more recently. We have a long history with both organisations. However, this approach with being able to access data across a number of, I suppose, region, but in the past with DHBs was very tricky. But now that we are at least in a regional space, we're able to support and understand and gather information to help better, achieve the healthcare services that meet the demands of our whānau and our community. So big, huge thank you to our partners. I suppose if we ask the question, what if we have a gentleman who comes to an ED? We've got a question online, and thanks, Nee, for that. James wasn't sure if this was serious enough for ED, but didn't know where else to go. We have many whānau who are workers. They are generally healthy and active, and maybe registered with a primary care physician, however, has something that goes wrong. And, they have a thought about what's available for me. And I think for us here in Te Whatuora, this is a very common, and actually for many providers, actually, this is very common. How do we support whānau to access the right care at the right time for the right level of needs that they have? We have whānau who wait and see, just to see what will happen. They may go onto the internet and try and find, the answers to their concerns. They may not be able to get to healthcare because of other commitments. So I think for us, as we've gone through this research project, a key component is actually about how do we support whānau to access care for the right level of care that they require for the symptoms they need treating for. It's great that we have services that are 24 hours available, and also are able to help whānau know what is out there in the community. Also, reconfirm, ED is a busy place, there's no doubt about that, but actually people who need emergency medicine should be coming to the ED. And that is a key finding for us. This is not about offloading volumes and workload. We want people who need emergency care come into emergency care departments. And also, if they don't need emergency care, what else is available for them? What other options in our community services is available? And, cost for some whānau is a huge barrier. It may make you think, I'll just wait off and see how this goes. But that time of them needing assessment can make it really difficult to then treat them when they do come in. So, services that eliminate or reduce the cost barrier for whānau is fantastic. So for us in the research, we are excited to see how we progress this, and we look forward to working with our partners around what services can be enhanced, adapted, strengthened, and ensure that our whānau are getting care in a more timely way. Kia ora.
Thank you, Melody. That's awesome. I think, Michael, if you want to take us through the key findings, and then we'll flick to some questions that we've got for the slides, and also some that we've got in the Q&A.
Yeah, sure, Jess. So this is the numbers behind that summary slide, and you can see there, this is the top tables, the presentations avoided because of Healthline. So these are the people who, well, these are estimates of people who went to Healthline that we think would otherwise have ended up ED if Healthline hadn't been available. And you can see the bottom line is ED presentations that could have been avoided if the people gone to Healthline rather than going to ED. So we've got the total numbers there and across each area. And notice we've validated those numbers with the Waikato and Taranaki, but we haven't had a chance to validate them with Bay of Plenty and Lakes then yet. So that's kind of still to come, that validation. So the numbers of Bay of Plenty and Lakes may change a little bit.
Beautiful. Thanks, Michael. I've got one question to kick us off, and it is you know, we all love our regions that we live in, and I did live in the Bay of Plenty for a while in the Te Manawataki space, and I did watch the Opotiki Matatini performance yesterday, and wowza, I can see why you might want to choose the Bay of Plenty after that, but why the Bay of Plenty, or why the Te Manawataki region and not Northland where I'm living, or, you know, Central or Te Waipanamu where we've got other whānau in? So yeah, can you give us a bit of context into Te Manawataki, the chosen ones for the research?
I can, Ruth, you're going to go? You go.
Oh, you ever go first if you like, Michael. I can give you a clinical aspect of it, and Michael, maybe you can give the other bit.
Yeah, I mean, from my perspective, Jess, it's because we've got you know, good connections with Melody and Matthew Parsons in the Waikato, and that also means we have availability of the ED data. So the ED data sets are different for each of the areas, and we were able to pull those together and standardize them to some extent. So part of that was you know, good relationships already. Part of it was it's an important region for Whakarongorau, and part of it was, you know, the data was available for us to do that analysis.
Beautiful.
Ruth, if you got something, I'll add to that. Yeah, I think the other part for us is that we know that there are parts of Aotearoa New Zealand that use Healthline quite heavily. So Canterbury, for example, are really fantastic users of Healthline. So another piece of work that we were really interested in doing was that comparison. So if we look at the Waikato, we've also got you know, it's a large Māori population. We've got a Māori you know, pathway through our Healthline process, and it's also got a large distribution of rural, you know, smaller rural hospitals, which have got a lot of pressure on them. So, and we know that the data is great, right? So I think all of those things, you know, play a part, and it's a big region. You know, it's the largest. Yeah, we often think of Northland. I mean, Northland's got a big Māori population, but actually, I'm pretty sure I'm right, Melody, that you know, the Waikato actually has the biggest Māori population when you take all of those areas together. So there's obviously you know, an interest there.
Yeah, beautiful. Thanks, Ruth. I mean, it's hard to not choose Te Manawataki. We get it, we know. But yeah, really great to have some of those key points highlighted out. Michael?
Yeah, I'd also add, Jess, we're not finished yet. So Northland may well be next on the list. I mean, we can do this analysis for other regions as well.
Beautiful. That's really cool. And I think another kind of a tag on to that question is we saw some of those big hospitals kind of represented, and then how are you accounting for the smaller ones within those districts? So we know within Bay of Plenty we've got Tauranga Hospital, and then we've got Whakatane Hospital, which does exist. We all know that now because it's got a manager. How do we know that difference in the research in our rural and maybe smaller hospitals being segmented out of the research, or are they being treated the same? Like if you were to come to Northland, we've got kind of rural hospitals which have A&Es, not necessarily ED. So how is that being managed in the current research?
So I'd say, Jess, for the data we're looking at is just the ED data from that we have available from the different hospitals. So, for instance, in Taranaki, it's Base Hospital and Hawera Hospital. In Lakes is Rotorua and Taupo. So yeah, I think the A&Es and the smaller ones, and we may have to look at differently. But also a little bit just to do what Matthew and Melody tell me. So look at the EDs that they've specified are the ones we need to look at.
What is that? Researcher Rule 101, stay in scope. Cool. Over to you, man.
Yeah, I was just going to say, I think it's a really good question, and this is the first cut. I think the second cut definitely does need to look at those rural hospitals or smaller hospitals differently. The reason being is that we know that actually, you know, in urban centres and bigger centres, you tend to have things like urgent care clinics and other options, especially after hours, where it doesn't happen so much in the rural areas. And when we look at the data, there definitely is a much higher proportion which are triage 5s, which tends to be stuff that some of it could actually be dealt with in telehealth. So I think that would be one of our segmentations that we do when we move into the next phase.
Yeah, beautiful. I'm going to flip off script slightly, team, and go to the Q&A. If you also want to, panelists, go through the Q&A and answer any of the ones that you've got, we've got a few questions in there. Lambert's asked a question, what percentage of the population does this represent? Melody, do you know that off the top of your head? That's a tough one.
It is. So Te Manautaki, in this study, obviously it was very difficult to pull the data for tairawhiti, and so they weren't included in this data set. But we look at Te Manautaki, it's just over 900,000 whānau in our community across a large proportion of I would say the middle of the North Island. Yeah, we obviously in our first cut of the data have been able to put some percentages around the overall presentations to our EDs and what that self-care group could look like.
Beautiful, thank you. I'm impressed that you knew that data off the top of your head. That's pretty impressive. There's a few questions in here that kind of are wrapped up in this one question that we have prepared. So I'm going to go and ask our question, and then hopefully that answers some of the other ones in the Q&A. And it is, how did you measure Healthline's intervention impact? And I think some of the questions in our chat are kind of off that around, what was included in that telehealth appointment, who was the clinician involved, what is can you dive into the detail a bit for us?
Yes, so I can tell you from a data point of view, Jess, it's so we had all the Healthline information. We looked at those patients who were directed to self-care at home. And then of those patients, they had various diagnoses, clinical conditions, and that's where Matt's expertise came in. And so that was where the clinical risk categorization came in. So we categorized each of the self-care patients as being low, medium, or high risk. And depending on those risk factors, we had a probability of, if there hadn't been Healthline, would they have presented to ED, or would they have ended up going somewhere else, or take it, as you said, take it a chance and stayed at home. And then using those probabilities, that will give us the expected number of those patients that we would otherwise have gone to ED. And so that for us is, the best estimate we have of, at that level, how many Healthline people how many people that were treated by Healthline would have otherwise ended up in ED. So none of the people we considered were directed anywhere else by Healthline. It was just the self-care cohort.
Beautiful, thank you so much. Matt, do you have more details?
Yeah, I guess probably just to widen the question and then come back to the question. Yep. So for those that aren't aware of how things work, so we've got well over 100 clinicians which answer the calls through Healthline. So that's a combination of nurses and paramedics, mostly with a significant number of years of experience. Many which work actually remotely from home, and then and some which work in the major centres and the offices. They use a decision support tool called Odyssey, which was developed in the UK, is NICE accredited, and which we have adopted since I started with Whakarongorau since its inception 9 years ago. And we've New Zealandized it, and we've updated it and made sure that the language is appropriate for people that are calling in, but also that it concentrates on certain things, for example, rheumatic fever, and it's got extra question sets and extra questions which would allow that. Odyssey is Bayesian logic, so the combination of questions which are asked by the clinician feed into then sort of an algorithm which then gives a time frame for someone to be seen, and then based on that time frame, that actually then means where they're directed to. So like an extended red flag checker, with a lot more nuances. You get some people who ring up with various complaints, so that presenting complaint and multiple presenting complaints can be opened, and the questions work through until you actually get enough relevant negatives to say that actually this person is suitable for self-care or general health information. People actually ring up, get a short triage, but they actually want to know more about what migraines are and what to watch for, how to deal with X and Y that they've just been diagnosed with. And then, so we've got a group then that we know about over 9 years of data that are by age, by presenting complaint, and by outcome who tend to get self-care. And we sort of know that, and then using a sort of probability heuristic developed by myself, Ruth, and a few others, that was what we were able to give to university. So we do plan to refine that because it's a combination of using data and using clinical experience over time. But understand that is an important part of making some of these assumptions as well. But I guess when I looked at the numbers that came out of that, they felt about right. From my own ED perspective, I see a lot of people who are very well. They've maybe been pushed by a family member to present to the ED. They're young. They may not even have their symptoms anymore, but that was the only place they went to. And if they went through an accurate triage using Odyssey with a clinician and really good safety netting, I feel that we could actually keep that sort of number. We prevented that sort of number out of ED or keep them out in the future.
Kia ora, Matt. Thank you. Ruth?
Yeah, so just a slight segue there as well, because I guess when you've got a really crowded waiting room, what you don't know is who's really crook. And our triage nurses are exceptionally good. We have got really fantastic emergency department nurses throughout the country, and they do a great job of triaging in the ED, but they've got a very small amount of time, and things can change over 6 hours in a waiting room or in the car where you're waiting. So the other part of this is not only making sure that you get to the ED, so you don't go to the ED if you don't need it, but also that you do if you do need to be there. So I think it's that sort of teasing out that part, and ultimately if you're in the waiting room, knowing that people aren't deteriorating in there is something, I guess, of interest as well, if that makes sense. So otherwise you're looking for a needle in a haystack, right? So that's just that other piece we haven't really talked about, and the research doesn't cover that, but I think it's just important to note that's sort of a side, a side outcome, if you like.
Yeah, beautiful. Thanks, Ruth. Thanks, team. What a great little summary that was, and hopefully that provided our audience with a little bit of a deeper dive. I learned this week, and so hopefully some more people are going to learn the answer to this question. Is Healthline integrated with the region's paramedic call centres, and is there a referral pathway that cases that require an ambulance can be referred to? So, Matt or Ruth, have you got an answer?
That's in Matt's wheelhouse.
Matt designed it.
Sorry, just repeat that slightly.
Is Healthline integrated with the region's paramedic call centres? Right.
So the way that works is that if someone calls 111, they're identified as a lower acuity patient, they actually get put on a queue for a callback. Now, that callback is by a nurse or paramedic that actually is employed by Whakarongorau on behalf of the ambulance services, uses the same algorithms, has significant experience in emergency work, and then can direct them to the same place. So in terms of, there's two different ways you can come in and get a pretty similar service through that, either by 111 or by ringing Healthline, with a lot of the joined up technology and clinical governance that Ruth and I and others provide. In terms of if someone rings Healthline and needs an ambulance, then there'll be a warm transfer through to 111, and that could either be, about 4% of the time that's acutely unwell, or about 2% of the time an ambulance for transport. So that's sort of the way that those pathways work. Is that actually there's a similar, I guess, thing going on if someone calls 111 when they maybe didn't actually need 111, or Healthline will send a small number through to 111 acutely for an ambulance. Yeah.
Beautiful. Thanks, Matt. So the simple answer to that question is yes, they are integrated, and there's a really cool pathway that happens in the background, which I didn't know about until this week, which I think is a really cool thing for us to know within the sector. We've got a few other questions that are being answered in the chat. So if you do have questions and you're wanting them answered, please put them in the chat. There's a few comments in there too, which are really, really interesting. So I guess one of the things, and I think Liz is kind of, and Andre referred to it in their comments, is this is really interesting. We've got some people that we know we can keep out of ED. What are the next steps from here, and how do we kind of socialize this to the public? Liz has kind of said, you know, young people don't really do phone calls. Where's the app? Where's the other technologies that are coming in to support young people through that? Snapchat seems to be kind of the thing that most of our young people are doing. They've got all of the AI bots on there and are using that to check their symptoms and figure out what's wrong with them. There's so many different mechanisms around technology kind of really being leveraged at the moment. So what's the kind of, I guess, the overall next steps here? Is that a bit of you,
maybe
Melanie?
I can take some of those digital.
Oh, yeah,
maybe I can take some of the digital ones, and then and you know, because there's a huge amount to unpack there. In terms of digital pieces, we do actually have a Healthline online tool, and you know, that's something that is a particular passion I know for Matt. So you can ask him more stuff about that. But that does mean that people can get a call back. Now, and you know, I recognise that yes, there are social media. You know, a lot of people would like to access healthcare through social media, but we have to have a certain amount of caution around that in terms of privacy issues, but also in terms of people's data usage, right? So, I mean, Healthline uses a one-way video and image upload specifically because there is a low data need for that. You know, so our intent really is to get to those people who need us the most, and those aren't necessarily people with data. So phone actually still works really, really well. And young people have less of a health need. I mean, you know, by and large. So I think our target audience doesn't, you know, sort of remains in those other groups. Doesn't mean to say that that isn't necessarily on, you know, it's definitely in our radar. You know, the AI is definitely in our radar, but it has to be done safely, securely, in a co-designed manner. Really important. And I'll hand over to Melody for maybe the more of the ED sort of parts of that.
Thanks, Ruth. And I think the last bit actually is around a co-design approach. So with providers and our ED staff, it's looking at what's going to work for their areas, as Matt raised earlier. There are different approaches, different setups across the country around EDs. There are big, large urban EDs like we have here in the Waikato, but then we've got to think about how we work collaboratively with our rural EDs, different makeup, slightly different at times, numbers and types of patients going in through there. So a one-stop fix is not going to be a solution, and we have providers, we have great providers within Aotearoa, and it's around how do we allow local engagement, local leadership, clinical leadership, and engage across the sectors to ensure that we're actually achieving access for our whānau in a much timelier way. So there is still a lot to be done in this area, and whilst the research has been extremely beneficial, a great partnership, we still have a lot of work to do together to actually find solutions that best meet the community needs.
Beautiful. Thanks, Melody. And we've just had a quick one from Kieran, which hopefully can be answered quite quickly, is did you find the ability to use video over just audio decrease the chance of ED presentation? I'm not sure if that was in scope, Michael, looking at the different modes.
I can answer it though. It wasn't in scope for this particular piece, but we published a paper on image upload. So you can see some information there on image upload So that's peer reviewed. In terms of video, see, Matt's going to answer this as well, but video is amazing. You know, one-way video is a thing of beauty. And if you had told me that I would be using one video, I would have told you you were absolutely insane, but it is absolutely a thing of beauty. You get beautiful views of tonsils, you get great views of kids with their chests, and it definitely makes a difference to your disposition decisions both ways, you know, Matt.
Yeah, I was just going to completely agree with you. We've gone through the process when I started with Healthline of having neither of these technologies. The Venetia team then built image upload, which allowed us to take images or get images sent through, I should say, free from service users, so that we can actually see the picture as we're asking the questions, and of course, especially for dermatology type complaints and for injuries, that really mostly improved the case in terms of able to much more reassure, but occasionally shows something way worse than what the person was describing. As we've moved to video, we've also found a real benefit in pediatrics, where we're really trying to get it used in all situations for pediatrics. And then in certain other situations, we find that the video is really helpful as well, especially if we can't really get a good feel across the phone for the person or the whānau is describing. We recognize with our clinicians that sometimes, you know, with video, not so much with image, it can cause a slightly longer consult because of connectivity issues. And so we just sort of work with our clinicians to use video in the right time. It doesn't have to be all the time, but I think generally when it is used, it's beneficial.
Beautiful. Thank you both. That's great. Great answer to the question there. And also for people that aren't keeping up in the Q&A, Damien has just asked if the paper is going to be peer reviewed, which Michael's confirmed it will be. Is looking to get published or with peer reviewed, which is really exciting as well, and great to start to create a pool of evidence around this type of work that's happening. As a wannabe researcher, there isn't actually a lot out there in this space, so it's really great to start to really bring some good New Zealand research to that pool of information in there. Yes, this webinar is being recorded and it will be uploaded to the Collaborative Aotearoa website, our Collaborative Aotearoa YouTube channel. Yeah, we still use YouTube. It still works a dream. And Whakarongorau will also be sending it out through their channels and distributions as well. So you can, if you've got friends that have got FOMO, it's okay. We got them covered. We're going to wrap up with a few more questions. If anyone on the line's got a few burning ones, do get them through. Ruth, I'm going to ask you one, which is, what opportunities do you see for better integration with primary care?
Oh, crikey, Jess. And look, you're sitting in a webinar here without any GPs in it, right? So my mother was a GP. I worked as a GP receptionist. I'm not sure that I can speak with any authenticity on that, but you know, I do want to acknowledge that emergency physicians and GPs continue to have this argument over triage category 4s and 5s. You know, and I think we need to park that. So that's one thing I would say. You know, we need to avoid that bun fight and focus on patient outcomes. And what we do know is that patients do better with continuity of care. You know, primary care is really important here. So in terms of integration, you know, when we talk about integration, that could mean many things. You know, I'd love to see a pathway where, you know, Healthline could navigate patients who do need to get to a GP directly into their usual provider. I think that would be like gold. As it stands at the moment, we do send you know, summaries through to our primary care colleagues, and as you've also heard, or you've stated before, that you know, a third of the people who call us will get safe stay-at-home advice. You know, so it's not our intention to try and send everybody through to general practice. You know, a good proportion of people can be served from home, and I think. You know, I think it's also important to acknowledge that not everyone necessarily needs to see a doctor. You know, there's, you know, pharmacists, allied health professionals, you know, physiotherapists. So there are other sort of integrations that we might sort of consider. I mean, Matt spends quite a bit more time, probably more than I do, and with our general practice colleagues. So I'm not sure whether he wanted to to add anything more to that, or?
Yeah, I guess I was just probably going to say that so in the last 2 years, we've sort of had integration of telehealth with at least 2 emergency departments, and we've had it with urgent care clinics as well. So with, I think, variable success, there's sort of if you've got good pathways, the triage nurses are engaged, and you've got sort of buy-in from wider stakeholders, the clinical directors of the department, and also others, including operations managers, then you can work through clinically safe groups to actually move into telehealth. But I think some of those do need then telemedicine or doctor service with prescribing and other things, but some of those need a triage. And I think having that nurse in between a doctor is cost effective personally. If of course things aren't engaged and things don't quite work out to plan, then you don't get the for those it's investments, change in models, people get a bit frustrated. You can see how things get turned off. So one of the things which worked in urgent care clinics was they were hesitant about having telehealth, don't tend to do a lot of telehealth just generally, but towards the end and closing time, when they're about to close or at capacity, having the option of people that were walking in and actually, instead of getting turned away, to then be kind of re-triaged through telehealth, and then whether to go to another clinic, whether actually go to ED, whether actually go home self-care, and obviously with worsening advice, was actually seen as a real benefit. So not specifically answering the question about general practice, apart from the fact, as Ruth said, that all the information does go back to that person's GP and primary care. I think there was a question in the comments about once someone's already there, can you turn them around? And there are situations when you can, but there are definitely there's less of an opportunity. It's better to have them triage first and then present with the knowledge that they've actually been sent into the right place at the right time.
Yeah. Beautiful. And I think something that we've been grappling with within general practice in the healthcare home model of care is, not only, the right place and the right time, but the right clinician or the right healthcare professional. And I think, Ruth, you alluded to that a little bit in your whakaroa is, our GPs are fabulous and we love them so much, but there's also all of these other people in our care teams that are able to work quite effectively to solve problems for patients and support them in their care journey. So I love that kind of step in there to make sure that we're not just getting them to the right building, but we're also helping them get to the right professional within that building in a really effective way, which helps really streamline that patient journey. Mike's asked what I already had on my list as my next question to ask, and we don't really like asking this question, us Northlanders, because we're all about seasonal pressures, not winter pressures. But winter is, not that any of us want to admit it, but it is coming in 2025. And what is the role of this research, I guess, in that space? What can this do to help us prepare better for winter 2025? Melody, what is Te Whatu Ora gonna do about winter pressures this year, and how do we link this into some of the winter planning corridor? And what are your thoughts around what the sector should be doing to respond to winter this year? So we might use this as one of our closing questions, and we might do a full sweep around the table, because I'm sure you all got a good hot tip for the sector here. So we'll start with you, Melody.
Kia ora, and thank you, Mike, for the question. Look, I think we can surely say that many areas across the country probably aren't feeling that there's been much of a summer, if we're talking about winter volumes versus summer volumes. And the capacity and demand has been reasonably constant across the country. So I think, yes, we do see some respiratory illnesses during the winter. That's a typical view that we see, and that then we have, obviously within Te Whatu Ora Hospital and Specialist Services, a key program of work around acute flow and improving whānau getting into hospital, out of hospital in a really timely way. For us, around some of the learnings, I think it's been key about the collaborative approach that we've taken with Whakarongorau, and our communications experts have been linking in very closely, and will continue to link in closely over the next few more months around how we support whānau to access the right level of care at the right time. But yeah, the last week has been quite incredible. The comms, the media exposure, and I think a joint effort that we recognise whānau need to have better access, and there's a lot of work for us to actually do that. It's not a simple question, to be fair, because there are a lot of players in this, but be reassured that everyone in this space is absolutely connected.
Kia ora. Thank you, Melody. We might go to you next, Michael.
Yeah, thanks, Jess, and thanks, Melody. That makes my answer quite short now. I think one of the questions about peer reviews, so getting a peer review publication out there that we can point people to. Here's evidence. Certainly, once that happens, then we can put it out amongst the research networks that Te Puna Matatene's got deep connections throughout the motu, beyond health as well. I often put some of my research stuff on LinkedIn, and that seems to get certain people that maybe wouldn't get to otherwise. So I think really just getting the news out there. Yeah, because from my perspective, I thought there would be significant numbers, and they are probably actually larger than I thought in terms of particularly the how Healthline is helping avoid people going into ED. So I think getting that word out there that it's a really good place to call first, if you're not sure, I think it's really important. What?
Kia ora, thank you. And love a good researcher and a publication, so we're all hanging out for that one. Ruth, what have you got? What do you think we should do around seasonal pressures?
Oh, look, I mean, this is a systems approach, isn't it? And as Melody says, a co-design process, and we always go into winter and we've never done enough. We had a great bit of seasonal pressure support with Healthline, post-COVID, and we had some really, really great information coming from there. We could actually support the telehealth nurses and paramedics within Healthline with doctor resource. There's lots of stuff that you can do, but you need to be mindful also that there are workforce pressures, there are other pressures, all impacting at the same time, and our primary care colleagues are struggling as just as much, if not more, than our secondary care colleagues. So I don't have any really fantastic answers. I think we just need to keep on chipping away, and I think collaboratively is the only way we solve these problems, together. Sorry, I wish I had a silver bullet, but
Yeah, beautiful, Ruth. Thank you. And Reggie's kind of started it off in the chat, so feel free to add your comments in too. Reggie thinks that the ED discharge summaries, to avoid the term follow up with your GP, and talk about potentially where appropriate, think about the seek help from Healthline, or Healthify has lots of information on this, and what are the things that you can do to have self-determination of your health and look after yourself. So I think what a great tip, Reggie. Must come from the Hawke's Bay, I reckon. Matt, what's your tips for winter pressures?
Just before I go to that, probably that comment from Reggie. So I've definitely seen a shift at Middlemore with our colleagues of Ruth and mine about, what used to be more frequently, saying follow up with GP, 2 or 3 days, maybe relatively lively, I think is the word to use, you write it there, I think people are a bit more conscious now about when to follow up with GP, what investigations have been ordered, and obviously now things like POAC and having to tick that you will take responsibility for investigations or follow up if you haven't contacted the GP. So I feel that things are turning there. I think it's probably actually at an RMO level where people are struggling more than SMO level. The ones that rotate through probably don't realise the impact on primary care by even writing that, and the patient reads it, hopefully they read what and then do what they say. In terms of winter. So I think we mentioned Healthline Online, where people can actually enter their details into Healthline Online and get a callback, so they don't have to be sitting in a queue, which at times can balloon out a bit. Generally is very good, I think, waiting times at Healthline, and then get a call back before making that decision and putting that trigger on where to go. So I think that will be an addition which we're looking to improve for this winter. The second thing is, about 2 years ago, we had an RSV outbreak, and it swept the country. And we actually changed our algorithm and decision support and our advice slightly to our clinicians, and then to give out to public. And we increased our threshold as to what was needing to be sent in. Generally, the sort of the systems that we use are quite cautious with children, and actually, get people in for an in-person assessment. Whereas we think now that we've got video, now that we've got more comfort with our algorithms, we're actually able to dampen down how many people need in-person care. So if that is sort of happening again, so we see something that we can actually shift, we will jump on it, and we can change things quite quickly, either in the decision support tool and or our messaging out to our clinicians to do something differently. So we'll keep an eye on respiratory presentations like we always do, week by week when they're starting to ramp up, and see if there's any trends or patterns, working with public health units, Health New Zealand, and various others as well. But I agree with Ruth, it's a bit of a system thing that we all kind of need to realise all bits of the system and do this together. One organisation can't do this alone.
Beautiful. Thanks, Matt. That's a really great summary to wrap us up. Marie's just put in a perler right at the end. She said, did the research find that people who aren't enrolled with a primary care provider were more likely to present at ED? And is this group also a higher user of telehealth? Does anyone know?
So we did have PHO enrollments and not in the data. Off the top of my head, we didn't look at if they're high users of ED or telehealth, but that's certainly something we can have a look at. I think that's a really good question, Marie. And I wish I could whip up some R code to figure that out for you right now, but we don't have time.
But we'll find out and we'll let you know, Marie, because I'm with you. I think that's a really interesting piece. And I'd also like to just throw in there, Michael, we want to know what model of care the practices that are working. So if they've got a healthcare home model of care within that practice, are their patients also less likely to be presenting to ED? So that's a practice that's doing some of that clinical triage in that initial phase. So we can talk more offline, but we'll get some information through to that. What an awesome discussion, team. What a great way to spend our Wednesday together, and to learn a little bit more about how we can solve for some of the big problems that we're having within our Aotearoa health system at the moment. Just to kind of wrap us full circle, we can help some people with telehealth solutions that are presenting to our ED as our kind of simple answer here. And we want to keep our EDs ready and open for the people that do require them and do need the services that are available in there. So it's going to take a collaborative approach. It's going to take a multifaceted approach. There isn't one answer that's going to solve for all of the problems in this space. But really need to be able to discuss tonight some of those solutions and some of the ways in which we can support whānau to stay out of ED, get the care that they require, and get well, which is one of the most important things that we're all trying to achieve with the patients that we are seeing. I'm going to wrap us up with a karakia. It's been an absolute privilege to host this webinar and bring everybody together to have the kōrero. Ruth, Matt, Melody, Michael, thank you for the work that you're doing. Thank you for initiating this research and making it happen and getting it across the line. It is going to help all of us in Aotearoa, both from the research world to the policy world to the application operations world, get things done in a kind of slightly different way and helping to really pull together some really compelling evidence. So thank you, thank you, thank you, thank you to all the people that joined us online. You're the bomb. You've come and spent your Wednesday evening listening about ED reduction via telehealth. You guys are so great. Go and enjoy the rest of your evening. I'm going to wrap us up with karakia, and I look forward to seeing you all again soon. Ko te pū, te more, te whū, te aka, te rea, te wainui, te kone, te whē, te kore, te pō, ki ngā tangata Māori, ngā rangi rawa ko pāpā, ko tēnei te timatanga o te ao. Ka kite koutou, have a beautiful evening. Pō Māori.
Thanks so much, Jess.